So metabolic syndrome is a very important systemic condition or a syndrome which has got a lot of other components, and we talk about the various components which will constitute the metabolic syndrome. The prevalence of the syndrome is increasing worldwide, and periodontal disease is considered as a part of the metabolic syndrome. Metabolic syndrome is referred as syndrome X, which is very important. It is called as syndrome X, or it is called as an insulin resistance syndrome. It is called as insulin resistance syndrome, and it describes cluster of symptoms which are associated with CVD, cardiovascular disease issues, and metabolic alterations. And one of the very important metabolic syndrome risk factors is abdominal obesity and insulin resistance. You all should be aware that metabolic syndrome is characterized by multiple disorders, which also has got oxidative stress as one of its major etiopathogen factor which is involved. And this syndrome, as I mentioned, is called syndrome Max, which is given by Raven. It was also called as Raven syndrome. And then this syndrome has got a lot of components, as I mentioned, which includes hyperinsulinemia, hypertension, hypertriglyceridemia, and visceral obesity. So subsequently, it's an insulin resistance syndrome. So it is a syndrome which has got multiple metabolic issues which are constituting it. And one of the component of metabolic syndrome is also periodontal disease, to the surprise. And this is originated from a pro-inflammatory state. Now, a pro-inflammatory state in the body, which can happen because of multiple reasons, will contribute to insulin resistance, and insulin resistance per se also leads to inflammation or promotes inflammation. So vice versa, there is an association which leads to insulin resistance and overall metabolic syndrome occurs. When you look into the picture, you will see that metabolic syndrome has got various associations. When you look into, you can talk about periodontal disease, its contribution, obesity or dyslipidemia, which also causes adipokines. Then you have got diabetes, which releases age, advanced glycation end products, which again leads to increased inflammation and decreased chemotaxis, so immunity falls down, and also hypoglycemia. So this picture shows you the pathophysiological mechanisms which are underlying the onset of the metabolic syndrome. Now, there are various risk factors which are involved. There are few are the common risk factors like physical inactivity, sedentary lifestyle, aging, hormonal imbalances, genetic predisposition, handicapped people, senior citizens, atherogenic diet, lot of fatty diet. These are all common fundamental risk factors. There's no discussion on this, but there are some specific risk factors like this lipidemia. That means there's a disbalance in the lipid levels in your body, elevated triglyceraldehydes, low HDL, high LDL, high TGs, elevated BP, and elevated blood plasma glucose levels are all specific risk factors which will lead to metabolic syndrome. In 1998, WHO has mentioned that presence of diabetes mellitus, and these are the following factors. You can see blood pressure, diabetes, increased glucose tolerance, increased obesity, and microalbuminuria. That means presence of albumin or proteinuria are the factors. But then we accept the NCEP. NCEP is National Cholesterol Education Program criteria in 2001, which said that there are at least three of the following should be present. At least three. At least three can be, one can be an obesity. And obesity can be measured by waist circumference, which is more than 102 centimeters in males and 88 centimeters in females. Triglycerides are more. HDL cholesterol is less. I hope you all know that HDL cholesterol is when it is less, it's a bad marker. Remaining cholesterols high are a bad marker. So you have to understand that HDL is a good cholesterol. That is why when it is less, it is not good for us. Be a blood pressure more than 130 by 85 mmHg, and fasting blood glucose is 110 mg per deciliter, more than that. So these are the criteria which will determine the metabolic syndrome. And the main definition of metabolic syndrome, according, this is very, very important, according to the International Diabetes Foundation, 2005. This is one of the recent now. 2005 International Diabetes Federation, IDF, has mentioned that obesity is standard. It's a common, like means obesity, central obesity, which is defined again as a waist circumference, plus two of the following factors. The two can be either increased blood pressure or a increased blood sugar or a reduced HDL. Any of the two among the three plus obesity will constitute a metabolic syndrome diagnosis. So to get a diagnosis of a metabolic syndrome, we all need to know what is the waist circumference, how waist circumference is calculated, how do we do it, and even triglyceride also has to be considered. So as I mentioned, there are some of the risk factors are general risk factors. Some of the risk factors are general. Some of the risk factors are specific to us. So based upon the risk factors and based upon the type of association, we need to calculate what is the main association here. So based on that, the complications of metabolic syndrome, which can land up into a cardiovascular disease, a stroke, maybe a cerebrovascular disease, or a very high diabetes. So this figure shows you that when there is a lipotoxicity, that means when there is an increased lipids, hypertension, lipid abnormalities, insulin resistance, all that will lead to a beta cell. When I talk about beta cell, I'm talking about pancreatic cells. When the beta cell will fail, there will be glucotoxicity, high glucose. When there's high glucose, what will happen? Obviously, the symptoms of diabetes like vascular issues, constriction, inflammation, everything happens, and that leads to this. So, in general, also, with and without, see, most of the patients who have diabetes will have hypertension. This is common. They're all common metabolic alterations. But then when you constitute everything, the terminology is given to as metabolic syndrome. And these patients are found to have periodontal disease as well. Now, when we talk about obesity, obesity is defined as a BMI more than 30 kg per meter square, with an overweight categorized as a BMI of 25 to 29.9. That is 30. The male pattern obesity is abdominal obesity is different, whereas the females, in males you see an abdominal obesity, in females you see a glutofemoral obesity, pear shape obesity you will see in females. And how do you assess obesity? One of the main common factors for assessing obesity was BMI, but BMI has a disadvantage as it does not give you where the body fat is distributed. So body fat distribution is assessed by waist hip circumference ratio. There are other tools like subcutaneous fold of fat can be calculated by a caliper or a bioelectric impedance analysis. So you should know those things are also available. So now this is one of the very important factors which actually explains you how obesity and periodontal disease are connected, which is very important. Now obesity or adipose tissue releases adipokines, appetite hormones, cytokines, and because it is also a source of an inflammatory cytokine release. All these things will lead to inflammation and immunodeficiency. When there is inflammation in the body, it will lead to insulin resistance. Obesity can also lead to the change in your dietary habits, can lead to change in your microcirculation because there is atherosclerosis. Then there can lead to change in the intestinal microbiota. There will be hyposalivation, and overall your diet is affected, and it will all go and affect because there's hyposalivation and everything. There'll be biofilm, there'll be bacterial load. Overall, it leads to periodontitis. So this is one of the factors. Second important factors is whether it is bacterial factors, which is because of the gum disease, periodontitis, obesity, environmental factors. The same person can be a smoker, same person can be an alcoholic, lack of physical activity, obese, cannot brush or do not want to brush, has an issue in brushing. So overall, all these factors, whether it is genetic, environmental, periodontitis, or bacterial factors, or obesity, that will lead to elevated synthesis of inflammatory cytokines. You all should be aware that when we talk about pro-inflammatory cytokines, interleukin 1, interleukin 6, TNF alpha are all pro-inflammatory cytokines. When these cytokines increase, there will be an increased inflammatory state in your circulation of blood, which will lead to chronic diseases. So now in this, the periodontitis is contributing into systemic inflammation, which you all know very well. So when the question is asked by how periodontitis contributes into metabolic syndrome, because periodontitis is a source of, because it is a source of inflammation caused by the bacteria, and because the inflammation is caused, and because of the periodontitis, the inflammation will lead to systemic inflammation. There will be systemic inflammatory markers which are raised, which contributes to the chronic disease because there's an hyperinflammatory state. That's how it contributes to it. So that is something which is very important. Now, periodontitis also leads to obesity. Like periodontitis, as you know, periodontitis is there, then there's a tooth loss, there is a mobility, there is an oral aesthetics, the oral aesthetics are compromised, bad breath, everything happens. So what is going to be affected overall is the masticatory performance, which leads to again obesity. Periodontitis has its own effects on systemic circulation in terms of cytokine release, inflammation, and periodontitis also sometimes leads to cytokines, which are again indirectly stimulating adipokines, again inflammation. The moment there is inflammation, what happens? Insulin resistance. Insulin resistance, then what happens? Hyperinsulinemia, which again leads to resistance and obesity. So whether it is a genetic factor, whether it is a socioeconomic factors, lifestyle factor, aging factor, these are common in obesity and periodontitis. And obesity periodontitis connection is a very important correlation and a link, which is explained in an article by Pichon et al. Pichon et al. Is a classic landmark paper on which there's a lot of description given, especially about adipokines. Adipokines are cytokines released by the adipose tissues like adiponectins, leptins, dysphatins, resistance, omentins. You should know these pro-inflammatory cytokines, which are released by the adipose tissues, which are stimulated by the inflammatory state of the circulation, and indirectly also by the periodontal bacteria or periodontitis, effect of periodontitis also, and they also contributes to adipokines. So obesity, inflammation, periodontal disease, classic paper 2007, published in an absolute classic journal, Journal of Dental Research, is by Pichon et al. They have explained what was the first connection of periodontitis. It was done on rat study. What was the rat study? When was it done? How the association is explained? Everyone should go through Pichon's paper. Then when we talk about diabetes and periodontitis, you all know that what happens in diabetes, whether it is a type 1 diabetes, which is autoimmune because of the inherent nature that the cells are not there, so insulin is not secreted, or a type 2 diabetes because of hypoglycemia or obesity, what happens is there is a protein kinase activation, which will lead to exaggerated host response. So you know that how diabetes leads to periodontitis. How periodontitis leads to diabetes is also, you all are aware that periodontitis also contributes to systemic inflammation, which indirectly leads to insulin resistance. All this is explained by a group of people, especially you need to go through Prishaw's paper and Taylor's paper. Taylor et al. Has done a lot of work. Prishaw has done a lot of work on diabetes and periodontitis and their correlation, which is again important. Now, this is again very, very important. This is again taken from the Prishaw's paper, who has mentioned that diabetes will lead to age accumulation. And you know that age and rage gets correlated. So rage is a receptor for age. When they interact, what is the output of the interaction of age and rage? The output is pro-inflammatory cytokines. There's a dysregulation of inflammatory cytokines. One part. Adipose tissue is there, obesity is there, that releases adipokines. So what happens when there are adipokines are released? What happens when this is released? Again, there is a dysregulation of the dysregulation of the tissue happen. So when there is obesity or when there is the diabetes or hypoglycemia, what happens is the pro-inflammatory cytokines will increase. Again, IL-1, IL-6, TNF alpha, and matrix metalloproteinase increase. All these are leading to periodontal disease. Excluding that, okay, diabetes and obesity are contributing towards periodontal disease is one aspect. The subgingival biofilm, the lack of oral hygiene, the bacterial factors are again super adding contributing to the periodontal disease. So periodontal disease is also happening because of all those reasons also. So you also need to understand that there are a lot of studies which have been done on metabolic syndrome. Now, metabolic syndrome has got one of the studies by Morita et al. In 2010 has mentioned that this long-term studies that increase risk of 60%, that is odds ratio of 1.6 times of metabolic syndrome patients when they found there was a follow-up for 4 years. Then Morita et al., the same group of people in 2011 has also shown that the risk is increasing and there's a significant risk, statistical significant risk is there. Then Tanaka et al. In 2018 have done a 5 years follow-up study, and they mentioned 11.1% of the participants develop metabolic syndrome, means patients who are already having periodontal disease. So you can see so much of work has been done. And when they have done an intervention study to actually know whether the impact of periodontal therapy on the outcomes related to metabolic syndrome. Okay, so there is by Acharya et al. In 2010, significant improvement in periodontal parameters in both the groups after the therapy and reported significant decrease in the levels of highly sensitive CRP. CRP is again an acute phase protein. Lopez et al. In 2012, okay, 2013, 2017, all of these studies have mentioned that there is an elimination. Whenever you're doing a periodontal treatment, definitely the periodontal inflammation goes down. But then they also found that systemically CRP is reduced. I just wanted to add on this that systemically CRP, that is an HSCRP or high sensitive CRP or CRP, is one of a very important systemic inflammatory marker. Then you can refer loose paper on that. Okay, and these are the systemic factors, and there is a fall of these systemic factors, including triglycerides sometimes after the periodontal intervention, which shows that the intervention of periodontal therapy can make the situation of metabolic syndrome little better in few cases. So effect of dental intervention on improvements in metabolic syndrome patients. This was an RCT which was done quite recently, or this year itself, I should say, 2021. Okay, in the British Medical Journal of Oral Health. And the primary outcome of the study was focusing on the waist circumference, which is as simple as that, because that's the best way of measuring the visceral fat. As a conclusion, the combination of intervention, dental intervention, and lifestyle guidance improved anthropometric and periodontal status of patients. So now, even the recent 2021 Doak et al. Paper has also mentioned that by doing a dental or a periodontal intervention on these patients, you are working on improving the patients. You know that when the patient has hypoglycemia and when there is a periodontal intervention, definitely the glucose level falls down. This was introduced by Taylor. There are a lot of people who have worked on decreasing the working on the metabolic control of diabetic patients by doing periodontal intervention. Similarly, metabolic syndrome also does, and now comes the systematic reviews. In systematic reviews, you have got Nebali et al. 2013. They mentioned that is an increased odds of presence of metabolic syndrome in presence of periodontitis 1.71. OR is an odds ratio. Then Watanabe et al. And co. 2015 has mentioned all the studies have shown positive association, odds ratio 1.52 to 4.70. Then 2018, Dowd et al. Again, the same thing. Now, in very few situations in periodontal literature, we find positive or a strong associations of metabolic syndrome. Yes, definitely. There is an increased relationship, but definitely still work is going on the periodontitis and its definition. But multiple systematic reviews have given a positive association to us. Then 2010, Chaffee and Weston, they also found a positive association, and Suverton et al. Also has found. So all these have seen that the odds ratio is minimum to minimum 1.23 or 1.5, goes up to 4.4 to 4.5, which is a big number. Okay. So these are all the systematic reviews. These are all a variety of studies, and we need to focus on these studies, and we need to make sure that the consistent association which is found between the periodontitis and obesity definitely has got an increases. This is one paper, impact of periodontal therapy on outcomes related to obesity, Suresh et al. They took 30 obese and 30 normal weighted people. They did not find much association, but they have seen that the systemic oxidative stress levels in both the groups has reduced. However, plasma reactive oxygen metabolite levels showed a great reduction in normal weight individuals and overweight individuals, because this is may not be a very longer follow-up period. But then you also, at this point of time, you also have to understand that oxidative stress is very important, very important. Oxidative stress gives you a lots of association between both of them. See, what you have to basically understand in this case, that oxidative stress is a correlating thing between any part of periomedicine, whether it is periodontitis and systemic inflammation. Oxidative stress, that means reactive oxygen species, which are released during this oxidative stress. Oxidative stress happens when there is a high chances of infection and inflammation. So there will be an oxidative burst which happens because of this, and which releases reactive oxygen species free radicals, which causes tissue damage. So that is one of the reasons why periodontitis also happens and systemic inflammation also happens. So impact of that on obesity is directly or indirectly connected to each other. That is something very important. Then impact of bariatric surgeries on periodontal status. This has got a little negative association. So bariatric surgery is, I guess you all know what bariatric surgeries are. 2018, D'Souza et al., for their systematic review, they reported no difference in cal bleeding probing depth before and after bariatric surgery. Fontaine et al. In systematic review 2018 again observed a significant increase in inflammation. So in terms of bariatric surgery and its association, they have not found. There was one study between BP, arterial hypertension, and periodontal status in morbidly obese individuals who are candidates for bariatric surgery. So obesity and hypertension are candidates for cardiovascular problem. However, morbidly obese individuals, hypertension, have got a very high prevalence of periodontitis. So when you take patients with arterial hypertension, obesity, diabetes, candidates for bariatric, periodontal status is bad. That is accepted bad. When you do an intervention, not periodontal intervention, when you're doing a bariatric intervention, when you're doing a surgery in addition to that, and you again check the periodontitis parameters, you don't find much significance. There are multiple factors which are contributing to that. Just by doing a surgery and you check it in a month, you can't find all that, because periodontal inflammation has also got something to measure. That means without doing any periodontal inflammation, just by doing a bariatric surgery, you cannot find that benefit out of it. So significantly, you have seen that bariatric surgery and periodontitis parameters, there is no much association which is seen. Clinical periodontal conditions in individuals after bariatric surgery, systematic review has mentioned no much influence. You can say as a neutral influence. So this completes your topic. This is full on with literature, full on with papers, and this is very, very important for you to understand that all these authors have mentioned the importance of metabolic syndrome, its association with the systemic diseases, and how important it is to maintain the periodontal health if you want to maintain the systemic health, which is very important to be considered in those cases.